Albuquerque and adjunct professor of radiology at the University of New Mexico in USA. So this, I think, it's a virtual lecture of the professor. Okay.
Linver, speaking to you from the United States. Unfortunately, I'm not in Cairo as I would like to be, but due to a family situation, I could not be there in person. But I want to take a moment to thank Dr. Rasha Kamal and her committee for inviting me to come back to the BGIICEC. It's a pleasure to be here even remotely. So we're going to be discussing tomosynthesis and approach to interpretation. So what are the advantages of tomosynthesis? Well, the studies have shown that it decreases our recall rate tremendously and at the same time improves our cancer detection rate, both huge advantages, which further result in a decrease in patient anxiety, they don't have to be called back as often, and a decrease in our downstream overall costs of doing breast imaging. And at the same time, there's an increase in positive predictive value. So how does the tomosynthesis work? The acquisition is pretty remarkable. There's an X-ray tube that goes across the breast, producing a variety of projection images, which are then reconstructed into 1 millimeter slices that are then displayed in a scroll-like fashion on our workstation so we can scroll through them almost like you're looking at a movie, as you know. Now, in addition, we still need a 2D image, and this can be obtained as a separate 2D image, but now can be created synthetically from our tomosynthesis slices. So either way, we do need the 2D image because we really need an overview of the breast still. We also need to compare to the previous studies, and that can really be done best with the 2D. And we need to do a side-to-side comparison of our 2D images from right to left, and we need to compare to any possible calcifications because we get a nice superimposition on the 2D, allowing us to see an entire cluster instead of just individual calcifications on various slices. Now, to do this, we have to have a very well-organized screening protocol, a hanging protocol, and you can do this a variety of ways. Just be consistent. Be consistent. What I do is I start with the current exam, looking at it in the 4-on-1 overview to look to see if there are any gross asymmetries from one side to another. If I have previous studies, I also compare these, of course, looking again for any change over time. Then and only then do I look at full resolution on the MLO views, comparing them side to side, and the CC views. After I review these at full resolution on the current study, I then do what I call the 4-quadrant zoom evaluation, looking for small masses and calcifications in more detail. And I do that by individually looking at each quadrant both on the CC and the MLO views. After that, then I compare this 2D to the 3D. And I put my current 2D study in the middle. I put the tomosynthesis view on the right. I put the previous 2D view on the left. And then I slowly go through my tomosynthesis views, going back and forth, trying to see if there's any abnormality present whatsoever. I would stress, please go slow because the abnormality may only be on 1 or 2 slices. And I go back and forth to see if it's real. I do that in the right MLO view. I do it in the left MLO view the same way, going through slow. I do it in the right CC view the same way, going slowly through the tomosynthesis images, looking for any possible abnormality. And then I do it again for my left CC view. So I do them individually, going through very slowly, making sure that I don't miss anything on any particular slice. Just be consistent every time you do it. Then, and only then, do I look at my tomos slices in full resolution on the zoom. And then I can find any small abnormalities that might be present. So that's basically what I do. Again, going slow and going back and forth again. My trademarks always, always, always. So To do this well, you must understand the specific tools we have available to us with tomosynthesis, and the scroll bar is probably the most outstanding of these. The scroll bar allows us to localize where things are on the tomo images very specifically. On the CC view, the scroll bar is oriented so that you can pull up any slice, depending on where you mark it, and you can see if it's toward the feet on the CC view or toward the head. The H for head, F for feet, with slice number 1 always being at the feet. So that's where the detector is. So that's how we use that for orienting our slice number 1. On the MLO view, the orientation is such that the scroll bar is showing us that slice number 1 is on the lateral side, because that's where the detector is, on the lateral side, medial lateral. L for lateral, M for medial. And again, slice number 1 always at the detector side, which is on the lateral side by convention. They're always oriented in just that way for purposes of consistency. Now, if you're looking at 90-degree views, like the lateral medial view, then the detector is on the other side, so it's on the medial side. So slice number 1 is where the detector is. That's the medial slice, so medial side. And so therefore, that's where the detector is. That's where slice number 1 is in the 90-degree lateral medial view. Let's take a look at a CC view and see how it helps us to know where the scroll bar is. You can see an area of architectural distortion here. Where is it located? Well, it happens to be in the middle. It's not toward the top, it's not toward the bottom. We know the lesion is lateral, but we don't know exactly where it is top to bottom. But here it tells us that it's in the middle, so it's probably around 3 o'clock. In this particular case, we can identify not only this mass, or this area of architectural distortion in the middle, but there's another lesion lower down. How do we know it's lower down? Because it's on slice that's toward the feet. So we know this one is probably at 4 or 5 o'clock. It's lateral again, and it's further down in the breast based on the location that we see where the scroll bar locates this particular slice. Now, when we go to our MLO view, in this particular case, both lesions are seen, both the area of architectural distortion and the smooth mass. But where are they located? They're both in the lateral side because they're toward the L, that's where slice number 1 is, as we know. And so they're both toward that side. So we know they're lateral, which we knew from the CC view. So we can identify the localization, we can localize a lesion pretty closely depending on where it's located relative to the scroll bar. So it's useful to use that location, slice location, to figure out where we are in space with a particular lesion. Now, where is tomosynthesis most helpful? Architectural distortion, as I just showed you, it's very useful for that, and for masses. Here's a case where the patient had previous surgery, but that's not what I want to show you. There's another lesion here, and it's very small. Can you see it there? It's so tiny. Just a little tiny spiculated mass. I'll blow it up a little further so you can see it better. Hopefully you can see it now. Very tiny spiculated mass. Notice it's best seen only 1 or 2 slices, and then it's gone. So again, this is the value of looking slowly, even for these little tiny masses. Here's the best slice to see it on, and you can see it's a spiculated mass. No chance of finding this in the other projection. But with tomosynthesis, we can find these small spiculated masses. Here's the CC view within the 2D again, and here it is on the best tomo slice. Look at how tiny that lesion is, and yet we're able to identify it unequivocally with tomosynthesis. This was, of course, an invasive ductal carcinoma. Well, that's good for architectural distortion of masses. What about calcifications? Does tomosynthesis have a value here? It does. It does in particular situations. It does not have any real value if you're working up something diagnostically. You still have to do 2D views. Why? Because the intrinsic resolution is not as good as on 2D, and you cannot use the magnification mode. You cannot use the small focal spot. So therefore, it's not good for diagnostic, but it is good when you're looking at the screening tomosynthesis. Here, it has several advantages over 2D. First of all, you can eliminate superimposition, and therefore you can see the calcifications better. And it's good, especially in dense breast. You can find the precise location of calcifications in space, as I just showed you, using the scroll bar. Excellent for skin calcifications. And it's better visualization of the surrounding tissue. That is, if there's a mass that happens to be located that you can see only on tomo around the calcifications. for that superimposed tissue situation, look at this case here. Here we saw some tiny linear calcifications right in the middle where that circle is on the 2D. And I was very concerned about these until I looked at the tomosynthesis. Where are the calcifications? They're inside of a blood vessel. So we know these are totally benign. We can dismiss this case without having to do a diagnostic workup using tomosynthesis alone. What about for precise location, how helpful they can be, especially for skin calcifications? Here's a case where you see some calcified fibroadenomas, but that's not what I want to show you here. If you look closely, there's some clusters of worrisome calcifications identified there. But when we looked at the tomosynthesis, where are they located? They're located on slice number 1. What does that tell us? They're right along the detector. They're in the skin. And to verify that, we can see those black holes, which represent skin pores. This was just powder trapped in skin pores. No workup needed. We can identify these unequivocally on tomo alone because of the location. And it allows better visualization of the surrounding structures. You can identify an associated mass with calcifications. Here is a case where you see calcifications. Is there a mass around it? There is. And it's well circumscribed and a little lobulated on the CC projection. On the tomo images, on the MLO projection, you can see there's a very nice, smooth margin to the entire mass. They're all contained within it, and it looks like, and what it is, it's got to be a fibroadenoma. Totally benign, does not need a further workup because we can see it has features of a benign fibroadenoma. Now, for screening, all women benefit from tomosynthesis, but younger women have the greatest benefit because they have the densest breast, as you know. So those are the ones that we are going to see the most benefit from. We saw this dramatically in our practice. When we evaluated our studies, we found 48% decrease in the recall rate in the women who were undergoing tomosynthesis in our practice. And the greatest value was that we could eliminate these vague asymmetries. Here was an example of such a case. I saw this area here. I was very concerned about it being a true mass in that medial side, very asymmetric compared to the other side. And here was the MLO view, equally worrisome. And yet when we looked at the tomosynthesis, we could just see all the way through the mass. As we go through this slowly, all the way through, it never came into focus. Never came into focus as a true mass. On the MLO projection, the same thing. I was so worried about this, but clearly all this represents is thickened, benign glandular tissue. There was no need to perform an ultrasound, no need to perform additional diagnostic mammograph views. We were done, and we could eliminate any need for a recall. So helpful. Now, screening tomosynthesis also can act as a diagnostic study, as it did there, when you see a mass or anything worrisome, because you can streamline or obviate the diagnostic workup, you can better characterize margins, therefore you can decrease the need for any additional mammographic views, and sometimes you can go right to ultrasound without having to do any additional mammographic workup. Here was an example. You can see here's an area of thickening on both the CC and the MLO projections on the 2D. On tomosynthesis, look how worrisome this area is. Look how worrisome it is. Oh my gosh, there's a spiculated area right there. But look how well you see it on the CC view. What about on the MLO view? Let's take a look. Here's the enlargement on the MLO view, and I think you can appreciate again how worrisome this is. Very well seen. In fact, beautifully seen. Not only, and here's the slice, you can see that you can see it the best on. Look, there's no need. You can't possibly do better than this view and this view from our tomosynthesis, both on the CC and the MLO. We don't need to do anything more in terms of a mammogram. We could go right to doing our ultrasound for further evaluation. No additional spot views are needed at all. And sure enough, on ultrasound, we can easily identify, knowing exactly where this was, we can identify a spiculated mass. A hypoechoic has features of what it was. That was an invasive ductal carcinoma. No additional spot views necessary. Tomosynthesis at screening acted as a diagnostic study as well. Now, you can also identify the location of a mass or any kind of a lesion on screening, and therefore it's acting as a diagnostic study as well. You therefore need fewer additional views for localization and a more focused ultrasound as well. Now, it is important to remember that the resolution on tomo is not what it is on 2D. Therefore, especially for calcifications, you still must do spot magnification views with 2D if you see worrisome calcifications on your tomosynthesis views. You can't use tomosynthesis to evaluate calcifications completely. You've got to do the spot magnification, because if you don't, you're going to lose that 30% more information that spot magnification views with 2D gives you. You can see here the resolution is not as good. Here's the 2D, which you see worrisome calcifications, and here they are in the 3D, the best tomo slice. They're still fuzzy, and that often is the case with calcifications on tomo. You've got to do 2D spot magnification if you're worried about them. Now, there are some future changes we can expect, and some of these are already here. Synthetic 2D, as I mentioned, is now available and is on almost all machines worldwide. So you don't have to do an additional 2D view. CAD for the synthetic 2D view is now available, as it is for the 2D. And stereotactic biopsy for tomosynthesis is here as well. And you're going to hear a lot more about that from Dr. Shilpa Lad very shortly. What about CAD for tomosynthesis? This also is almost here. AI has done a tremendous job in helping us with tomosynthesis. It's going to make our lives much more pleasant in the future. And you're going to hear more about AI from Dr. Mansour very shortly as well. So going forward, we can expect other applications, that is, contrast-enhanced digital mammography with tomosynthesis is being developed, and many more changes in terms of the workstations to improve our workflow and beyond. We can expect many more changes in the future. I'm happy to say, so please stay tuned for this very exciting advance we see in tomosynthesis. And I thank you for your kind attention. Shukran.
Thank you, Professor Michael, for your excellent lecture. Now, the next speaker, Professor Shilpa Lad.